Hello everyone, and welcome to this episode of the 𝘫𝐸𝐴𝐶 video series, where we delve into high-yield topics that frequently appear on the NBME and USMLE exams. In this session, we're focusing on primary biliary cholangitis, a condition that plays a significant role in liver pathology and is frequently tested on the step 1 due to its autoimmune nature and its association with other autoimmune conditions. Here is a 45-year-old woman who presents with severe pruritus that has progressively worsened over the past year. She also has a recent diagnosis of Sjögren's syndrome. Her laboratory results show elevated alkaline phosphatase and mildly elevated liver enzymes, which, combined with her clinical symptoms, strongly suggest PBC. The key point here is that PBC often presents with severe itching, especially at night, which is related to the cholestasis-induced buildup of bile acids in the blood. The connection with autoimmune conditions like Sjögren's syndrome is also a critical detail for your exams, as it underscores the autoimmune pathogenesis of PBC. Next, a 45-year-old woman who presents with pruritus, jaundice, and fatigue. Her laboratory findings show elevated alkaline phosphatase, elevated gamma-glutamyl transpeptidase, and mild hyperbilirubinemia. A liver biopsy reveals dense lymphocytic infiltration of the portal tracts and granulomatous destruction of interlobular bile ducts, confirming the diagnosis of PBC. This case emphasizes the hallmark histological findings of PBC, granulomatous inflammation leading to bile duct destruction. The presence of anti-mitochondrial antibodies is a key diagnostic marker, making it highly relevant for step 1. In the third case, a 46-year-old woman presents with xanthelasma, a cutaneous lesion on the upper eyelid containing lipid-laden macrophages. This finding is commonly associated with hyperlipidemia secondary to chronic cholestatic liver diseases like PBC. The presence of xanthelasma in a middle-aged woman should prompt consideration of PBC, especially when accompanied by other symptoms of cholestasis. For the step 1, remember that hypercholesterolemia in PBC results from impaired bile excretion, leading to cholesterol accumulation. Next, a 52-year-old woman with a history of Sjögren's syndrome, presenting with progressive fatigue, pruritus, and mild hepatomegaly. Laboratory results reveal significantly elevated alkaline phosphatase and positive anti-mitochondrial antibodies. The underlying pathogenesis of PBC in this patient is similar to that of graft versus host disease, where T-cell-mediated destruction of intrahepatic bile ducts occurs. This case is crucial for understanding the immune-mediated mechanisms behind PBC and its association with other autoimmune disorders, which is a key concept for step 1. Finally, we have a 60-year-old woman presenting with fatigue, weakness, and ataxia, accompanied by hyperreflexia and a loss of vibratory sensation. Laboratory workup shows hemolytic anemia, suggesting a vitamin E deficiency. This deficiency is secondary to fat malabsorption due to PBC, which impairs bile acid secretion and subsequently disrupts the absorption of fat-soluble vitamins. This case highlights the systemic effects of PBC, particularly the neurological and hematological complications that can arise from chronic cholestasis and fat malabsorption. Through these cases, we've covered the key aspects of primary biliary cholangitis, from its clinical manifestations and diagnostic criteria to its systemic complications. Understanding these details is not only essential for the step 1, but also for your future clinical practice, as early recognition and management of PBC can significantly impact patient outcomes. Keep these cases in mind as you continue your studies, and let them guide your understanding of this important condition. Okay guys, here is another frequently tested topic in step 1 exam: hepatic encephalopathy, a 54-year-old man with liver cirrhosis who has been admitted to the hospital for worsening confusion and disorientation. On physical examination, signs of asterixis are noted, and the patient is unable to correctly identify the current month. His lab results reveal elevated serum ammonia levels, and lactulose therapy is initiated as part of his management. Now the question here is, what is the primary mechanism of action of lactulose in this patient? The correct answer is that lactulose enhances ammonia excretion by acidifying the colonic contents. This might seem like a simple concept, but it's a critical point to understand for both exams and clinical practice. Lactulose is a non-absorbable disaccharide that, once metabolized by gut bacteria in the colon, produces short-chain fatty acids. These acids lower the pH of the colon, thereby acidifying the colonic contents. This acidification plays a pivotal role because it converts ammonia, which is absorbable, into ammonium, which is non-absorbable. The ammonium ions are trapped in the colon and are subsequently excreted in the stool. This process effectively reduces blood ammonia levels, alleviating the neurological symptoms of hepatic encephalopathy. In summary, the goal of lactulose therapy in hepatic encephalopathy is to reduce blood ammonia levels by converting ammonia into ammonium, which is excreted in the stool. This is an essential mechanism to understand for your exam. Let's move on to another critical case that highlights the pathophysiology of hepatic encephalopathy and its precipitating factors. A 54-year-old man with a history of hepatitis C is brought to the emergency department by his wife after vomiting bright red blood. The patient is treated for gastrointestinal bleeding and admitted to the hospital. However, the next day, during morning rounds, the patient is disoriented and cannot identify the current month or his location. Physical examination reveals significant abdominal distension, gynecomastia, and asterixis, classic signs of liver cirrhosis and hepatic encephalopathy. The question here is, what is most likely contributing to this patient's altered mental status? The correct answer is increased absorption of nitrogenous substances by the gut. This is because gastrointestinal bleeding in patients with liver cirrhosis leads to an increased nitrogen load in the gut. The hemoglobin from the blood is broken down into ammonia, which is then absorbed into the bloodstream. Normally, ammonia would be detoxified by the liver and converted into urea. However, in patients with cirrhosis, the liver's ability to detoxify ammonia is impaired due to hepatocyte dysfunction and portosystemic shunting. As a result, ammonia accumulates in the bloodstream and crosses the blood-brain barrier, leading to neurological symptoms such as confusion, disorientation, and asterixis. It's important to recognize the factors that precipitate hepatic encephalopathy. In this case, the gastrointestinal bleed is a major contributor because it increases the nitrogen load in the gut. Other precipitating factors can include infections, electrolyte imbalances, and certain drugs like sedatives and narcotics. These factors either increase ammonia production or decrease its detoxification, thereby exacerbating the condition. In conclusion, the key factor contributing to this patient's hepatic encephalopathy is the increased nitrogen load from his gastrointestinal bleed, which leads to elevated ammonia levels in the blood. Managing hepatic encephalopathy involves addressing the precipitating factors, such as GI bleeding in this case, and reducing blood ammonia levels, typically with treatments like lactulose. Understanding how these mechanisms interact is vital for diagnosing and managing hepatic encephalopathy in clinical practice and on your exam. Let's jump into another high-yield case. Here we have a 50-year-old man presenting with several weeks of rash on his legs, joint pain, malaise, and fatigue. His history is significant for intravenous drug use, though he has been abstinent for the past 5 years. During the examination, we find palpable purpura on the lower extremities, hepatomegaly, and absent Achilles reflexes. Urinalysis shows hematuria, red blood cell casts, and proteinuria. Lab results reveal elevated blood, urea nitrogen, and creatinine levels, indicating renal involvement, and positive serologies for hepatitis C antibodies, along with low complement levels and positive rheumatoid factor. This presentation strongly suggests a diagnosis of mixed cryoglobulinemia syndrome, which is most commonly associated with chronic hepatitis C infection. MCS is a form of small vessel vasculitis characterized by the deposition of immune complexes, specifically cryoglobulins, which are abnormal immunoglobulins that precipitate at cold temperatures. In this case, the cryoglobulins are a mixture of IgM and IgG with rheumatoid factor activity, which bind to the Fc portion of IgG and cause widespread small vessel damage. The classic signs of mixed cryoglobulinemia syndrome include palpable purpura, glomerulonephritis, as seen here with hematuria and proteinuria, peripheral neuropathy, and arthralgias. The pathogenesis of MCS involves the activation of B cells, which produce cryoglobulins. These immune complexes activate complement, causing hypocomplementemia, and deposit in small vessels, leading to inflammation and tissue damage. Treatment typically focuses on addressing the underlying hepatitis C infection and managing symptoms. Now let's look at another case that builds on our understanding of cryoglobulinemia. This is a 45-year-old man who presents with a 2-month history of painless, non-pruritic purple lesions on his legs, along with fatigue, weakness, and fleeting joint pain. The lesions are palpable and non-blanching, which are classic signs of small vessel vasculitis. Laboratory studies reveal elevated creatinine, elevated liver enzymes, and a low C4 complement level, all of which point toward a diagnosis of mixed cryoglobulinemia syndrome. The most helpful next step in this case would be to obtain viral hepatitis serologies. Why? Because chronic hepatitis C infection is the most common cause of mixed cryoglobulinemia syndrome. In this condition, cryoglobulins, abnormal immunoglobulins that precipitate at cold temperatures, form immune complexes that deposit in small vessels, causing vasculitis, glomerulonephritis, arthralgias, and neuropathy. The immune complexes also activate the complement system, resulting in hypocomplementemia, which is why this patient's C4 levels are low. The link between hepatitis C and cryoglobulinemia is well established, and it underscores the importance of screening for hepatitis C in patients presenting with systemic vasculitis, particularly when they have associated liver abnormalities or a history of intravenous drug use. The treatment for mixed cryoglobulinemia syndrome focuses on managing the underlying hepatitis C infection, often with antiviral therapy, along with therapies to control the immune response and inflammation. In both of these cases, mixed cryoglobulinemia syndrome presents as a multi-system disorder with involvement of the skin, kidneys, joints, and peripheral nerves. The association with chronic hepatitis C infection is crucial for diagnosis, and laboratory findings like positive hepatitis C antibodies, rheumatoid factor, and low complement levels are key clues. Let's dive into another key topic for your Step 1 exam. A 26-year-old woman who was brought to the emergency department after nearly fainting at work. She felt dizzy and lightheaded, but didn't have chest pain or palpitations. Notably, she has a history of chronic diarrhea, having 10 to 12 non-bloody, watery bowel movements per day, often accompanied by abdominal cramping, with the diarrhea sometimes waking her at night. On examination, she showed signs of orthostatic hypotension, likely due to volume depletion from the diarrhea. Labs revealed hypokalemia and metabolic alkalosis. After treatment with fluids and electrolytes, a colonoscopy revealed melanosis coli, a dark brown discoloration of the colon with pale patches resembling alligator skin, strongly suggesting laxative abuse. Melanosis coli, a hallmark of chronic laxative abuse, is caused by the buildup of pigment in macrophages within the colon's lamina propria. This condition develops after just a few months of laxative use and is reversible upon discontinuation. The diarrhea in these cases is typically frequent, watery, and can occur at night, as seen in this patient. In summary, her chronic diarrhea, orthostatic hypotension, hypokalemia, and colonoscopy findings are indicative of laxative abuse. The diagnosis is confirmed with a stool laxative screen, and addressing the underlying factitious disorder is essential for treatment. Okay, again, here we have a congenital diaphragmatic hernia case. A newborn male who was delivered at 37 weeks gestation and immediately presented with respiratory distress, characterized by nasal flaring, cyanosis, and severe tachypnea. On examination, you notice a scaphoid abdomen, and the chest auscultation reveals decreased breath sounds on the left side, with bowel sounds heard in the left thorax. The question asks, what physical examination finding is most likely? The correct answer is absent bowel sounds in the abdomen, as the intestines have herniated into the thoracic cavity through a defect in the diaphragm. This displacement prevents normal bowel sounds from being heard in the abdomen. In CDH, the defect is most commonly on the left side of the diaphragm, which allows the abdominal organs, such as the intestines, to herniate into the chest cavity, compressing the lungs and causing respiratory distress. A scaphoid abdomen is a classic sign, reflecting the loss of abdominal contents into the thorax. Chest X-ray, in this case, reveals bowel loops in the chest, with a mediastinal shift to the right, further confirming the diagnosis. Early recognition and intervention are crucial, as CDH can be life-threatening due to severe respiratory compromise. Let's now explore another critical case, this time involving a 4-week-old male who presents for a routine visit. His parents have noticed yellowing of his skin over the past 2 weeks, and more recently, he has developed pale-colored stools and dark urine. On physical examination, the infant appears well but has icteric sclerae and jaundice extending to the upper chest. Lab results show elevated total and direct bilirubin levels. So what's causing these findings? The correct answer is extrahepatic obstruction of bile ducts, consistent with biliary atresia. Biliary atresia is a progressive condition in which the extrahepatic bile ducts undergo fibrosis, leading to cholestasis. Infants typically appear healthy at birth but develop jaundice, dark urine, due to bilirubin excretion via the kidneys, and acholic, pale stools within the first 2 months of life, as bile cannot reach the intestines. The liver often becomes enlarged and firm, as seen in this patient. Liver biopsy is the key diagnostic tool for biliary atresia, showing bile duct proliferation, portal tract edema, and fibrosis. Without timely intervention, usually through a 𝐶𝐚 procedure, the disease can progress to cirrhosis and fatal liver failure within the first few years of life. Let's jump right into those leptin-related cases, a high-yield topic you're likely to encounter on the Step 1 exam. In this case, we look at an experimental mouse model involving a homozygous mutation in the gene coding for the leptin receptor, which prevents it from binding leptin and initiating the normal signaling cascade. So, what relationship between BMI and serum leptin levels would you expect in a mouse with a leptin receptor mutation? In this situation, both BMI and leptin levels would be elevated. The leptin receptor mutation causes the animal to overeat, leading to profound obesity despite having high levels of leptin. This occurs because although there's plenty of leptin present, the body can't use it effectively due to the non-functional receptor. The brain doesn't receive the normal satiety signals, so the animal continues to feel hungry and gain weight. Leptin is a hormone produced by adipocytes in proportion to body fat content. Normally, leptin suppresses appetite and promotes weight loss by acting on the hypothalamus. However, in this case, the leptin receptor is non-functional, leading to hyperphagia and profound obesity despite high leptin levels. This is because the feedback mechanism between fat stores and appetite regulation is disrupted. Mutations in the leptin receptor are rare in humans, but illustrate an important concept in the regulation of body weight and metabolism. Next up, we have a 16-year-old girl who presents for a pre-sports physical examination. She has been following a strict diet and exercises for 2 hours daily. Her menstrual period stopped 8 months ago, though her menarche was normal at age 13. On physical exam, she has a BMI of 16.6, which is below the normal range, and shows signs of lanugo, a fine hair growth often seen in individuals with inadequate caloric intake. The question asks, what is the most likely cause of her amenorrhea? The correct answer is hypothalamic suppression. This patient's presentation is typical of functional hypothalamic amenorrhea, commonly seen in athletes or individuals who maintain very low body weights. The underlying mechanism involves reduced leptin levels due to diminished fat stores, which in turn inhibits the hypothalamic release of gonadotropin-releasing hormone. This suppression leads to decreased pituitary secretion of LH and FSH, resulting in low estrogen levels and secondary amenorrhea. This condition can be reversed with adequate caloric intake and weight gain, which restores the normal pulsatile secretion of GnRH and menstrual cycles. This condition can be reversed with adequate caloric intake and weight gain, which restores the normal pulsatile secretion of GnRH and menstrual cycles. Next case, we're looking at a 45-year-old man with a BMI of 38 who has been struggling to lose weight despite following a diet plan for months. He continues to gain weight and has difficulty controlling his appetite. Lab tests reveal elevated serum leptin levels. So, what's going on here? The key concept here is leptin resistance. Leptin is a hormone produced by fat cells, and in individuals with increased fat mass, leptin levels rise. Normally, leptin acts on the hypothalamus to reduce appetite and increase energy expenditure, keeping body weight in check. However, in many people with obesity, the brain becomes less responsive to leptin, a condition known as leptin resistance. Despite high leptin levels, the hypothalamus doesn't get the signal to reduce appetite, so the person continues to feel hungry and overeat, which leads to further weight gain. It's like the body has plenty of the signal 𝐸𝐻's leptin but can't process it, causing this cycle of overeating and weight gain. This concept is a high-yield topic for your USMLE exams, as leptin resistance is one of the primary reasons individuals with obesity struggle to lose weight, even when their hormone levels suggest they shouldn't be hungry. Let's move on to other case, which focuses on the relationship between leptin levels and fat mass. We have a 35-year-old woman with a BMI of 41 who presents with difficulty managing her weight. Her laboratory results show markedly elevated leptin levels. So why are her leptin levels high? The answer lies in the fact that leptin production is directly proportional to fat mass. Leptin is secreted by adipocytes, fat cells, so the more fat someone has, the more leptin they produce. In obesity, individuals have significantly higher levels of leptin due to their increased fat mass. However, here's the twist. Despite having high leptin levels, individuals with obesity often don't experience the expected reduction in appetite. This is because of the leptin resistance we discussed earlier. The brain isn't properly responding to the high leptin levels, so the body doesn't register satiety, and the person continues to feel hungry. This case helps to reinforce the concept that high leptin levels are expected in individuals with obesity due to increased fat mass, but these levels alone don't translate to effective weight control due to the development of leptin resistance. Let's wrap up with a case involving a 55-year-old man with recurrent episodes of jaw pain and swelling, which worsens with eating. He also experienced a tender mass under the left jaw, which was accompanied by a fever. His symptoms resolved with antibiotics, but this is his third episode this year. The most likely diagnosis is sialolithiasis, or salivary gland stones. Sialolithiasis is the most common cause of recurrent salivary gland infections, or sialadenitis. Salivary stones usually form in the submandibular glands and obstruct the duct, leading to pain and swelling, especially after meals when saliva production increases. The condition can be treated with hydration, moist heat, and sometimes the removal of the stone to prevent further infections. Make sure you master all the cases and concepts we've discussed in this video and in previous ones. These are frequently tested in the exam. Keep reviewing, stay focused, and you'll be well prepared for your step 1. Thank you for joining this episode of the Metacoccus video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.